that one child who dies is one too many. And there are more deaths that we see now, with COVID than we see with flu. And again, obviously this is one flu season, and that's now over a couple of years of COVID. But even if you take that 5 to 18-year-olds and you take that, last flu season and you triple it, to make it 3 years worth, it's still many, many more children who are dying of COVID than who are dying of flu. And then we know there's also a lot of collateral harms from COVID. So just the prolonged social disruption and school disruptions. It was really hard for our school-age children, adolescents, a lot of social isolation, reduced access to medical care, reduced access to resources, and a huge impact on mental health. It's just really a mental health crisis, particularly in our adolescents. And there's a lot of anxiety in being in school and anxiety from infection. So besides being directly infected, there's been a lot of other things that have gone on. So if we kind of focus in a little bit more on what we are now calling PASC or PASC, or post-acute sequelae after COVID, it's really an evolving definition, and it's because it's really become this sort of umbrella term for any of these post-COVID conditions. And it's a very wide range of things that people are seeing, both affecting physical and mental health. And the definition is actually a little bit different between the CDC, NIH, and the WHO. So I'm going to use the CDC definition, which is that if there are any of these symptoms that are being experienced by patients that are present 4 or more weeks after the SARS-CoV-2 infection, then that's now considered to be PASC or a type of long COVID. So sometimes these symptoms started with the infection and then continue past the 4 weeks, and that would be considered to be PASC. Or they sometimes actually, people get better from the original infection and then symptoms starts many months later, and that's also would be considered long COVID. So any kind of symptom that's, again, it's that 4-week mark. And that's because we know from a lot of viruses, actually flu is very similar, that people in those first 4 weeks after infection can have pretty prolonged symptoms, but then they usually end at 4 weeks. And so when we go past 4 weeks, that's kind of telling us that there's something else going on. The WHO uses a definition of 3 months, so they're actually using a much longer time frame, but this is what we're using with CDC and NIH. And again, these could be new symptoms, they could be recurring symptoms, they could be ongoing symptoms, and sometimes they could be exacerbations of an underlying illness that somebody already had. Symptoms also can fluctuate and sometimes can relapse. So people can feel better one day and worse the next day. They can be getting better and then they can get worse again. And one of the key definitions is having an impact on quality of life. So really the person is really feeling like that these symptoms are affecting their ability to function as well as they would like. So just to kind of show you the timing of what we're talking about here again, kind of pre-symptoms or there's this sort of, if someone's exposed to COVID, they, potentially had symptoms, people can be, may or may not be symptomatic. We know that there's actually a number of people who are asymptomatic, and people can be asymptomatic, not have symptoms, and still get long COVID. But for the acute COVID infection that happens, generally people are sick for about a week to 10 days. If they're immunocompromised, it might be for longer. At that time, they're shedding virus, so PCR positive, they're potentially antigen positive. And then we get out to this 4-week mark, and people either continue to have or start to have these other symptoms. And sometimes they can just last for a few weeks, and sometimes they can last for 6 months, 12 months, people are going into many years of having them. So what are some of the things that we've been seeing? So I'm just going to touch a little bit on long COVID in adults. It's not actually my focus here because I'm a pediatrician, but these are kind of a whole constellation of symptoms. This particular graphic is focusing on symptoms of long COVID in people who are not hospitalized during their acute phase. There are very similar graphics for those who have been hospitalized. I like to focus on the non-hospitalized group because that is actually the more common group. And you can see that really a huge number of different organ systems are involved. So if we look at kind of the neurological and neuromuscular, I'm not going to read everything, but I'll point out some highlights. So some really common things people are seeing are headaches, potential, walk and gait abnormalities. People talk about, having lost their taste or smell and it really being gone for a very long time. Visual disturbances, for example, musculoskeletal, people have muscle pain, joint pain. People have been complaining of gastrointestinal problems, nausea, vomiting, abdominal pain. The neurocognitive is probably what everyone has been talking about the most. So that's the brain fog. A lot of people have actually that kind of brain fog and fatigue during the acute infection. And there's a group of people who that really lasts a very long time. I was actually just talking to a colleague of mine who unfortunately had COVID in November and is now having long COVID symptoms. And it really is really hard, to do your job and to do all those things, particularly when you're having the neurocognitive issues, having trouble concentrating, confusion, things like that. The psychological manifestations are actually something that people are really paying a lot more attention to now, and it's really important. And it's fairly well documented, actually, of having an increase in anxiety, depression, sleep disorders, and also post-traumatic stress after COVID infection. It's really, I think, an important thing to screen for, an important thing to watch for, particularly in our adult and adolescent patients as well. Upper respiratory, people complain of sore throats, congestion, cardiopulmonary, breath, chest pain, cough. There is a lot of other things, skin rashes, hair loss, dermatological issues. This is systemic issue is just a real big, large fatigue that's really lasting. People really talk about just not being able to get through the day without having to take a nap, fever, dizziness, those kinds of things. So that's kind of the constellation of what people have been seeing in adults. And the big circles are the things that are very common. The small circles are less common because they're very bigger circles are the neurocognitive and the psychological, as well as the systemic, particularly the fatigue. Okay, so what about in children? So when we think about PAS-C in children, there's actually two different entities. There's MIS-C, which I'm going to talk about, and long COVID. There's also MIS-A in adults, so there is now a kind of correlate to it in the adults. So what is MIS-C? This is probably something you guys heard about. It really kind of came to the forefront probably about, now maybe kind of early 2020, I think, relatively early in the pandemic. And basically, it's a multisystem inflammatory syndrome in children. That's what MIS-C stands for. It's a relatively rare condition, although we did actually see quite a bit of it in New York City. New York City was one of the places that saw a lot of the original cases. Most cases occur in older children who are greater than 5 and adolescents. And the thing with MIS-C is that it occurs 2 to 6 weeks after the infection. So usually these kids had infection and got better, and then come in with this sort of profound changes that I'm going to review for you. And some of those kids, they never knew that they were infected. So they actually were able to see because of the antibody response, or they found out because they had a household contact. But these aren't necessarily kids who got very sick with COVID and then later had MIS-C. So in MIS-C, basically different parts of the body become very inflamed, particularly the heart, lungs, kidney, brain, eyes, and gastrointestinal organs. And it really is just the kind of hallmark is fever. And then oftentimes these kids present with stomach pain, and it's not subtle stomach pain, it's very intense stomach pain. Oftentimes their eyes could have conjunctivitis, diarrhea, dizziness, or lightheadedness, and they have a kind of a rash and then vomiting. And it actually looks a lot like Kawasaki. So oftentimes when these kids are being evaluated in the emergency room, they're kind of thinking about the two of them together, and then a little bit based on history, and they actually can be treated similarly. So as an outpatient person, if you see someone you think has MIS-C, they should go to the emergency room, because they basically, if they look okay right then, they can get very, very sick very, very fast. And a lot of these kids actually ends up in the ICU because they need a lot of blood pressure support. And then they're okay. They actually get treated, usually with IVIG, and then they're better. So it's really important. We aren't seeing much of this anymore. There's a lot of people who think that the original strain of COVID was more likely potentially to lead to MIS-C, because we're just not seeing it as much as we had before. So what about the other long COVIDs, the other part of PAS-C? So not MIS-C. But what about the long COVID that's kind of correlates to the adult symptoms that I mentioned to you originally? So for those children, there's a lot of that's unknown about the prevalence. So how many kids who are infected with the SARS-CoV-2 virus will end up with long COVID? And that's because the reports that are out there have very wildly different numbers. So early reports suggested that maybe it's 4% of infected children end up with having persistent symptoms. And then in some studies, it's up to 58%, which obviously is a very large number. There have been some more recent meta-analyses, so basically trying to pool together lots of different kinds of studies and try and get a little bit down to another number. And again, there's been this very high variability. So 1.6% to 70%, right? That's a huge difference. And in one of the kind of newer studies is kind of coming down to this number, maybe it's 25%. And so in general, people are thinking that it's probably around 10 to 20% of children who are infected with SARS-CoV-2 will end up with long COVID. And that's a lot of kids. That's 1.4 million children in the United States. So that's really a huge, huge number of children. And you can imagine how hard it is for an adult to function with long COVID, but it's really hard for a child who should be going to school and playing with their friends and doing all of those things. And so that's why there's a lot of now interest in making sure they're really understanding what's going on in children. So what are the most prevalent clinical manifestations of long COVID in kids? So you'll see a lot of these are actually very similar to what I showed you for adults, but I do want to go over them because they're not, some of them are, have different, more or less of them. So for the kind of neuropsychiatric, fatigue is really common. So that's one of the most common things that we see. And we also see a lot of these mood symptoms. So again, depression, anxiety, but also children who are maybe more angry and more tense. And so again, a really important thing to look out for. Sleep disorders are actually very common too, both insomnia, so trouble falling asleep, and also hypersomnia. So really just being overly tired, and then lots of poor sleep quality. So kids will talk about that they're trying to sleep and they're going to sleep very early and they just are exhausted. Kids also have that same brain fog that adults have. Headaches are very common, and as well as dizziness. For the cardiorespiratory system, kids complain of chest tightness, heart change, so palpitations. And then one thing to be really aware of is orthostatic intolerance. And so one of the things that we're beginning to see is adolescents, more often more girls, but not necessarily, with POTS type syndrome, so posterior hypotension. And so basically the way that is diagnosed with an active standing test. You're basically looking at kids when they're sitting, and then when they're standing, and you're taking their blood pressure and heart rate. And you're looking for these kids, actually their blood pressure doesn't really change, but their heart rate skyrockets when they're standing, and it gets worse as they're standing for longer. And so they basically just can't tolerate standing for long periods of time. And that ties into a kind of dysautonomia that we think is happening in response to the COVID infection, or after the COVID infection. A lot of these kids are also talking about exercise intolerance. It's another common thing. They used to be able to run all the time, and now they can't. They get really short of breath. They get very tired. And so we have a lot of referrals to our exercise physiology lab to really be trying to assess what's going on, because is it deconditioning? So is it that kids now are inside much more? They're not outside playing. They're not, they're now kids are back in school, but they don't have the active lives they had before. So is it that they're muscle deconditioned, or is it really actually that the COVID has affected their cardiopulmonary system and they really are not able to tolerate exercise? Kids talk about being short of breath. Some kids have a very long-term chronic cough, and then a lot of other things. So that same loss of taste and smell, joint pain. Some kids get hyperhidrosis, so really overly sweating, rashes, dry skin, loss of appetite. This idea of tinnitus is in the adult population as well. And it's actually a lot of the long COVID support groups that actually started to realize in patients talking to each other that tinnitus was actually something that they were, that a number of them were were affected with. And then you can see some eye problems, swollen lymph nodes, nasal congestion, and sore throat. So many things that are very similar to the adults, but a little bit kind of more honed in. And I don't think I put the gastrointestinal on here, but that's important as well. And I should have put that on. It's a little bit less common, but we definitely are seeing kids who are presenting with gastrointestinal problems, and some with actually gastroparesis as well. So you may have been thinking, as I was mentioning some of these things, that some of them seem to be overlapping a bit, right? So, if we look here on this side, there's, in acute COVID, there's sort of the kind of sneezing, nausea, vomiting, that we all have seen, fever, shortness of breath, but then also that middle part, cough, kids are talking about being very fatigued, they have headaches, they have sore throats, diarrhea, congestion. And that middle part are also long COVID symptoms. And then on the kind of long COVID side, there's the other things that I've mentioned. And so when does it cross over into long COVID? It crosses over to long COVID when those things are persisting again for more than 4 weeks. So if someone is having symptoms and they're gone by, the end of 4 weeks, we won't call it long COVID, but when they hit now their past 4 weeks, if they still are having, say, headaches, then that would now be considered to be long COVID. What makes this all really complicated is that these symptoms are not in a vacuum, right? And so, as I mentioned, there's all of this stuff that's going on with the pandemic. And so it's really important to try to separate out what is from the infection and what's from just living in the pandemic. And so this particular study is not a long COVID study, but I want to point it out to you because it was done by this wonderful researcher in my division, Danny Dimitriou, but it really starts to tease apart this idea that not everything is from the infection. So she has a cohort of mothers and babies that she follows. It's called the Combo Study. And she published this article in JAMA Pediatrics where they were very interested in children whose mother was pregnant with them and had COVID when they were pregnant, and what would happen. And there was concern about neurodevelopmental issues potentially with those children, because we know that some other infections, like for example, flu, you can have potential neurodevelopmental changes in infants if the mother was infected with flu, for example. And so they wanted to look at this kind of idea of kids who were not exposed to COVID in utero. And so they used a questionnaire called you may be familiar with it, called the Ages and Stages questionnaire. It's a good developmental screening tool. And they looked at kids who were exposed and not exposed, and they saw no difference. So communication, motor skills, problem solving, personal, social, no difference. But they had an historical cohort where they had done the same testing on, and these kids were born before the pandemic. And what they found was actually at 6 months, some neurodevelopmental changes in the kids who were born during the pandemic versus the kids who were born before the pandemic. And so it's just a really good reminder to all of us that just, being born in the pandemic and being a child in the pandemic, it really has very much changed, prior than any of the children from before. And so it was really birthed during the pandemic, not the in utero exposure that was potentially associated with differences in neurodevelopmental outcomes. And that's really important for us to know, because it does mean that all of these kids who were born, in that, particularly around that very stressful time, in that early kind of mid 2020s, that we're monitoring those kids and that we're making sure that they're developing appropriately and we're getting them early intervention and other things if they need it. So similarly, it's really important when we start to look at long COVID that we try and look at cases and controls together, because all of the things that I mentioned to you could happen just normally in children. And so a lot of studies are trying to look at now kind of saying, okay, we have kids who are exposed, who had infection, kids who weren't. Can we look up these symptoms in both and maybe kind of subtract out the prevalence that's happening just in normal, just children in the pandemic, and then try and get a better idea of what's being caused by the infection itself. And so there've been a number of studies that have done this. I'm just going to show you two that are here. This first one took 22 different studies with over 20,000 children and adolescents and tried to look at these pooled risk differences. And so the differences between cases and controls they found were really in the cognitive difficulties, headache, loss of smell, sore throat, and sore eyes, but not on these other things. And then another group of people looked at 21 studies and about 80,000 children and adolescents, and they saw a high risk of shortness of breath, dyspnea, and then a lack of smell, lack of taste, and fever. Another way to look at this is another study that looked at about 78,000 kids. This is actually focusing first on kids who are 0 to 5. And what you're looking at is you're looking at the right side of the bar. Those are the things that and I've also highlighted them in red, are where the cases, so those who've been infected with COVID, had a higher risk of having these things than the kids who weren't infected. So you can see here muscle weakness, loss of taste and smell, joint pain, headache, and fatigue. So more likely with kids who had COVID. What's interesting is that when you do these case control studies, sometimes you find things that are more often in the controls. So on this side, they found that actually fever, diarrhea, cough, and concentration difficulties were more likely in the controls, which is interesting because particularly for the last one, we would have expected the concentration problems to be more in the cases. So you can see that it can get kind of complicated when you're doing these kinds of studies. If we look at the little bit older kids, so this is now 6 to 17 years, again, those who had been infected were looking at respiratory problems, muscle weakness, again, that loss of taste and smell, again, that fatigue and dizziness, and now adding chest pain. We're looking at the adolescents and school age kids. And then this flip side, these kinds of things, actually, they were seeing more in the control patients. And again, also those concentration difficulties. So that's why it's going forward, it's important to basically, in these studies, to really do have a population that you can compare against so that you can, again, try and tease out what is just happening in the baseline population. There have been a lot fewer studies that have looked at kind of more of imaging or function testing or lab testing in long COVID in kids. And the studies have been mixed. So there have been studies that have looked at, potentially higher blood pressure, maybe some echocardiographic changes, definitely some lower performance on the exercise stress test. So I mentioned those kids who had exercise intolerance. There have been some studies that have shown EKG abnormalities, but they have been transient. And that study didn't show echo findings that went with those. Another one was saw these mild obstructive reversible pattern on spirometry. So these kids were having looking mild obstruction when they were doing spirometry, but then they had normal PFTs later and normal lung ultrasound, and they didn't have any long-term pulmonary sequelae. And then there was one small study that did look at brain imaging, and on PET scans saw potential involvement of the bilateral medial temporal lobes, the brain stem. Cerebellum, and the right olfactory gyrus. So just again, a smattering of studies, and really a lot more information is needed. So what causes long COVID? And we actually don't know the answer yet. There's a lot of different hypotheses that are out there. So the first is that acute infection, is directly causing end organ damage, right? Tissue damage. So there's obviously damage to the lung, there's potential damage to the brain, and then over time, because you've had that actual direct damage, you can have these symptoms. Another possibility is medical intervention. This is particularly for those who are hospitalized, just being on a ventilator, having just been very, very sick, there's things that can happen from that. There's also potential of exacerbated immune response. And that's actually what we think is happening in MIS-C. It's just this over exuberant immune response that's really happening later at that 2 to 6 weeks. And that's what's causing all of the problems at that point. There's a group that think it's actually viral persistence, which is that the virus itself, is persisting, and then there's potential places in the body where the virus is. We know that the lack of smell is actually direct damage to those olfactory neurons. And that's why it actually takes a very long time to come back, because you have to grow those neurons and grow those pathways back. And a lot of people who have lost their sense of smell from COVID talk about this weird phase in between when the smell is coming back, but everything just seems wrong, that they, things that they thought smelled great now smell terrible. And that's because these neurons are actually growing back and trying to find their paths again. And then there's a potential for autoantibodies. So again, antibodies that our bodies make to the infection, but it's actually attacking our body. Then there's another group of people who believe all of those things, but also have added more things. So you can see here the antigen persistence, the systemic tissue response. But there's also some people who think it's actually a potential of reactivation of viruses, like, for example, EBV virus, Epstein-Barr, or human herpes virus, where you were infected a long time ago, and then after getting COVID, that those viruses are being reactivated in the body, and that's actually what's causing some of these long COVID symptoms, particularly because we do know, for you take EBV, for example, some of the symptoms of long COVID really track with the things that people say with mono, for example, that like intense fatigue, for example. Other people think that maybe it's related to, there's this dysbiosis. So there's just your whole microbiome has changed potentially from having COVID. So people who are interested in looking at that as an option. There's also direct microvascular dysfunction. So we know that COVID can cause clotting issues. And so, maybe that's causing some of the problems. And then we talked about the autoantibodies and the immune response. So, lots of different potential ways that long COVID could be happening. And then there's this big plus here. Plus, there's also a lot of stress. So there's stress of being infected and being worried. There's stress from the pandemic. There's stress for caring for others. There's a huge economic stress and financial stress. There's social isolation and social anxiety, and there's educational losses, for kids who just basically lost a lot of time being remote. And then grief. There's people, many people have lost family members and friends and loved ones, and including, there's people who have PTSD. So there's all of the kind of biological causes of long COVID, and then there's all of this sort of other things around it too that can make the symptoms much, much worse. So what about treatment? Unfortunately, right now, the treatment really is depending on the individual symptoms. So, we're sending kids to cardiology or sending kids to neurology, and really treating those symptoms. And the hope is that through particularly the Recover study, that when we finally get to the clinical trial part for children, that we'll be able to ultimately identify and test different interventions for long COVID, because I can tell you we have, as part of the study, have patient representatives, and it really is just so devastating to adults and children who are suffering. So what are some limitations of the studies that were out there, and what's potentially different about the Recover study? So some of it is study design. So a lot of this are observational studies. There's could be lack of standardization of definition. So you can see a lot of these are trying to pool different numbers together. So 300 from this study and 400 from this study and 500, but if they define things differently and looked at things differently, it's a little bit hard to do that. There could be selection or misclassification bias, so who got selected to be in the study, how they were classified as having COVID or not having COVID. Sometimes there can be issues with recall, so trying to remember what happened. There can be issues with non-response or loss of follow-up. Time can vary from when the infection was, particularly, now it's been a long time, small sample sizes, and then some of them lack control groups. So that brings me to the Recover study. So Recover is this large initiative, really massive initiative that you may have read about, that was funded by the National Institutes of Health. And there are 4 different kind of large cohorts. So there's an adult medicine cohort, pediatric, an autopsy cohort, and then the one that's focusing on electronic medical records. And we're fortunate at Columbia to be one of the hub sites. So there's a few of the sort of pediatric sites that are running the COVID study, long COVID study, and then out of these hub sites, there are different sub-sites. So across all of Recover, there's about 100 pediatric sites who are running this. Recover stands for the Researching COVID to Enhance Recovery. And the idea is really to understand and learn about the long-term health effects of COVID. And the idea is to ultimately, we want to both prevent it and to be able to treat it. And this study is an observational study. I'm going to tell you a little bit more about it. So right now, the phase we're in is really trying to understand long COVID in kids, and then hopefully in the future, we'll be able to do clinical trials. It's a national project, so you can see there's researchers across all over the U.S. And ultimately, between the adult and pediatric cohort, there'll hopefully be about 40,000 people who are involved. So what are some of the things that we're trying to study? So we really want to understand a little bit better how many children are getting long COVID. As I told you, we don't really understand what percent. Why do some kids get long COVID and some kids don't? What's the potential biological, social, genetic reasons for it? What symptoms do children get when they get long COVID? How long are they sick for? Kind of what's the recovery trajectory? What causes long COVID to happen? And then how can long COVID affect later physical health, mental health? And really, we were very big concern about development in kids. So we know that there's so much development that happens in children, and really trying to understand, the effect of being infected at a young age could have on their development. So there are 3 big study aims to recover. The first is to understand that incidence and prevalence. So incidence is sort of the onset of symptoms, and prevalence if we're sort of doing this cross-section of how many kids have long COVID, and really understanding kind of what are the clinical and biological features, and really trying to understand that. The second aim is to understand the clinical course and recovery. Again, so how are kids doing over time, and trying to look at factors for risk and resiliency. So what are some of the things that hopefully we can understand so we can try and prevent it in the future. And the third aim is to really understand that pathophysiology and mechanism. So can we really begin to understand the sort of direct and indirect effects, all those ways I told you potentially that COVID could be, that SARS-CoV-2 infection could be causing long COVID, and we're kind of interested in all of those things. And so who can take part and recover? Basically anybody. So I'm focusing on the pediatric cohort. So we enroll children, their caregivers who both have and have not had COVID. It's actually very unusual at the moment to find people who haven't had COVID. There are a few kids left, but whether there are people who have or have not been infected, and we are going to enroll up to 20,000 children. There's a cohort focusing on babies, particularly infants of mothers who have been infected. Our cohort, we are enrolling babies, but not necessarily whose mother's been infected. And then preschool and school-age children, teenagers, and young adults all the way up to age 25. And it's really important for all of us and for NIH that recover really be representative of the population. That's really important, that we really are making sure that we're enrolling children and caregivers from all races, ethnicities, and backgrounds, because it won't help us to understand long COVID if we're really focusing only on one population. So what happens, and I'm going to show you a video in a minute, but basically it's a tiered study. So tier 1 is really remote, so answering survey questions. Kids can have this home blood test that they do and give us a little bit of saliva. And then some group of kids come in and do more survey questions, have a simple checkup, have more blood drawn, and then do lung breathing tests and EKG. And then a very small group of kids come in and do a much more intense imaging, primarily depending on if they were symptomatic, but they might have echocardiogram, they might have MRIs if their heart or of their brain, exercise testing, for those who have exercise intolerance, and then a lot will have neurocognitive testing, and there's some neurocognitive testing in tier 2 as well. And the guiding principles of recover really to make sure, as I mentioned, to focus on inclusivity and diversity, and really make sure that we really have a very diverse population, really to have good communication between recover staff and the public and our participants, to collaborate, to be accountable, to be safe, transparent, and to be accessible. And so they've worked really hard on making sure about all of those things. They've actually made these really beautiful brochures and flyers, both in English and Spanish, that really, and other languages as well, but that really focus on what is recover and why people might want to join. This is an example of the flyers. And people are definitely compensated for both, completing the surveys as well as for coming in. So it's really important that families be compensated for their time. So I'm going to show you the video, and hopefully this is going to work, because I think it's a nice kind of way to end. So let me, so you can see this. Okay.
Hi, thanks for your interest in Recover. By joining the study, you and your child can help us learn about the long-term effects of COVID, whether you or your child had COVID or not. We know you likely have questions. This video will tell you more about Recover and what to expect if you and your child join. Recover is a research study that aims to learn about long COVID. What is long COVID? Long COVID is when a person is sick many months after getting COVID. Symptoms can include trouble breathing, coughing, feeling weak and tired, and problems with memory or focusing. Adults and children can get long COVID, but doctors don't know why. COVID has changed people's lives around the world and has likely affected your life too. By joining Recover, you and your child can help us answer important questions like, why do some children get long COVID and others don't? What symptoms do children feel when they get long COVID, and how long do they feel sick? How does long COVID affect the child's health in the future, including how they develop? So who can join? Babies, children, and adults who have and have not had COVID from all races, ethnicities, and backgrounds across the United States. This helps us learn about long COVID in everyone. Up to 20,000 children and their caregivers will be part of Recover. What will you and your child do if you join? You and your child will be asked to answer survey questions about you and your child's health, use safe at-home kits to get a small amount of blood and spit. You may also be asked to have checkups or other tests. You and your child can skip any question or test you don't want to do. You and your child will not get treatment for long COVID during the study. Most people will be in the study for about 6 months. Some people will be asked to stay in the study for up to 4 years. If you want to join, study staff will tell you more about the study. You'll also get a consent form, which has more details about what you and your child will do if you take part, how much you'll be paid for your time to do surveys, checkups, and tests, possible benefits or good things that may come from being in the study, and possible discomforts or risks of being in the study. Joining the study is voluntary, meaning you choose whether you and your child will join or not. If you join, you can stop being in the study at any time. You and your child's safety and health is important to us. Study staff is here to watch out for you, including to keep your information private. Thanks for watching. We look forward to meeting you and your child and talking with you about Recover. Together, we can learn how to better prevent, test, and treat children with long COVID in the future. For more information, go to recovercovid.org.
So, for those of you who are interested in being able to talk to your patients about the Recover initiative, there's a couple of things potentially that would be great or be helpful. So, if they want to join, if you're in anywhere in New York City, or New Jersey, then we're able to we can actually enroll them at the Columbia study site, and we have an amazing bilingual team, including Dr. Vargas and all of her colleagues. And it's we've just set up a nice, warm pediatrics space for families to come in. And again, remember that the first part is all remote. We also have a lot of help for families who can't do things electronically. We can do it over the phone with them. We can bring them in to do it. We have all this Recover brochures, both in English and Spanish, as well as flyers. So any way to help get the word out. And the reason we joined the study, and particularly, is that we wanted the Washington Heights community to be reflected in long COVID research. We know that there were so many children and families who were really just a huge number who were affected by COVID, and we want to make sure that we understand the risk of long COVID and that they're represented in this research as well. If you want more information, then we have, when you can email directly, you can talk to Salabel. We also have a study email. It's peds_recoverstudy@cumc.columbia.edu. My understanding is sometimes some people are not in New York City, New Jersey. Maybe if you're listening from around the country, you actually can also go to the website recovercovid.org. As you saw from the map, there are Recover sites all over the country. So lots of places to be able to have families enroll. So I'm going to stop there and can answer any questions.
Thank you very much for this excellent exposition. I'm going to allow every any of the board directors member that we have here or executive committee, Dr. Paula, Dr. Roa, Dr. Douglas Mendez, Dr. Roldan, Dr. Gonzalez, Dr. Vargas, Dr. Reyes, if any of you have any questions. So let's start from our participants in the Zoom conference.
Okay, thank you so much for your presentation, Doctor. Do you have a video also on English, a Spanish version?
Yeah, so there's a version of this video in Spanish as well. Yes,
Okay,
absolutely.
okay, that's great.
Yeah.
So, do you have any idea of how many, or if you are following them, how many children and adults, especially in Washington Heights, are having long COVID symptoms?
Yeah, I don't have a sense. We don't really have a sense of the prevalence yet. Our particular site is primarily enrolling in Washington Heights, so I think we'll get a little bit of a maybe. We won't probably can't answer the question of how many are infected or are affected, but we'll be able to understand, particularly for our population, what are the kinds of symptoms that people are seeing. But we haven't. We're about we're going to enroll about 500 or 600 children, and we've enrolled about 300, right, Salabal, so far. So we're about halfway enrolled for just our area, Columbia, and then obviously across the country will be 20,000 kids. And for our families, probably about 50 or 60%, I think, are Spanish speaking currently.
Okay.
And is there a deadline for the enrollment in the?
So nationally they would like to finish enrollment by the end of May. We're doing very well as a site, actually, in being able to keep up with our enrollment. But it's potentially could go past, a little bit into June, but we're really trying to focus a lot of our enrollment and be able to get that done by the end of May. And that's just the enrollment, and then we'll follow these children over time. The enrollment will continue for those who actually have long COVID. So this enrollment is sort of for the general population, and then there'll be continued enrollment for children who were not enrolled originally but have long COVID type symptoms.
Another question, I mean, do you remember or could describe one of the children that you have encountered having the most serious sequela of this long COVID, the community?
Yeah, if I can say a particular case, but I can tell you some of the things that we've been seeing. Okay. So I think that the most common that we've been seeing is the intense fatigue. So really lots of kids who are very tired, have a lot of trouble concentrating. The kind of a lot of the exercise intolerance. We have a lot of kids who are actually going to see neurology. So a lot of children have a lot of headaches. So kind of like headaches, to sort of neurological headaches, trouble concentrating, and then the cardiac. So the chest pain, palpitations, exercise intolerance. And then we have also children who are having more gastrointestinal symptoms. So having more kind of diarrhea or having kind of trouble kind of digestive systems really processing. So that's kind of a lot of what we've been seeing. In general, in Washington Heights, there's just been a lot of increased behavioral health needs in adolescents. So a lot of anxiety and depression, whether it is tied directly to COVID infection, we don't necessarily know that yet, but I can tell you as a pediatrician, and you probably all have felt it as well, is a kind of a real crisis. And I think that COVID infection has played a role in that as well. So I would add that as a common symptom. And then our pulmonary group is, sees kids with sort of more long-term kind of chronic cough or having more kind of obstructive asthma symptoms as well.
And as a pediatrician, now that it looks like the pandemic has been decreasing because there's more people vaccinated, do you still see parents resistant to get vaccine against COVID to the kids?
We do. It's interesting. We don't see it as much in the teenagers as much, but we really see it in the under 5, just not a much less uptake. And it's funny, it's the opposite of flu. So flu, usually we see very good uptake in the kind of under 5-year-olds, and then the school age kids a little bit less than the teenagers less. And for COVID, it's a complete flip. And so you'll see a lot of the teenagers are vaccinated, and then less the 5 to 11-year-olds, and very, very few. This is nationally as well, but definitely in New York City and definitely in the Washington Heights community of real not good uptake in that 0 to 4 age group.
So what would you say to those parents that, how is the way that you approach those parents that still are hesitant to give vaccine to their kids?
Yeah.
What would be a better way to convince them?
Yeah. I should come back and do a whole separate talk on vaccine hesitancy. So I'll give you a short one, but so I think there's a couple of things. I think that kind of big picture is that I think someone said they lost the audio. Some of in general, for people to get vaccinated, they have to believe that the disease, that their child's at risk for the disease, right? So they have to believe and they have to believe that the disease is bad, right? So if they think that COVID's not a big deal and it's just a cold, like then they're not going to get their child vaccinated, because they'll look at this sort of vaccination as something they're doing to their child, right? So it's like a decision they're making to vaccinate their child. And so some of what we're doing is also talking about the risk of infection, that many kids have mild infection, but there are kids who end up hospitalized, or kids unfortunately pass away. And then now there's, we know there's this risk of long COVID, which can be very detrimental to kids and affect them and their health and development. So I think for some families, it's sort of understanding that their child is at risk. For other families, there's a lot of interest now in actually using motivational interviewing around vaccination, and really kind of talking to families and kind of starting to unpack sort of what are they worried about, what's their concerns, and then helping them identify what's the reason they would maybe want to get vaccinated. And then, ultimately, again, finding that kind of common ground with them, but leaving the decision up to them, but helping them identify sort of what that might be, and being able to answer their questions. And so that's sometimes, what we're doing as well. And then I hopefully getting the word out. I think that as more people get, more and more children are vaccinated, and there's more and more time. And, the FDA yesterday was just, kind of releasing their thoughts about potentially moving towards, everybody getting a new, booster in the fall, just like the flu vaccine. So, potentially, every year looking at new composition and getting the new vaccination. And I'm hoping it will become more like the flu vaccine, because for those of you who've been practicing for a very long time, you probably remember we went through this with the flu vaccine, right? There was, not a lot of interest in it, and then not for young kids, and then it was like, okay, for young kids, all right, and then kind of moving our way through. So I'm hoping we'll get to that point, but we're not there yet. I would say we do know a lot about this vaccine. It's a very safe vaccine, and it's good for protecting against, the very severe things that we're concerned about. So I'm definitely pro, as Salabel knows, or Dr. Vargas knows, I'm very pro vaccine.
Good luck. Okay, so we have a meeting coming up, so I'm probably gonna go over this information that you are presenting and see if all of us are in agreement to cooperate with this initiative. And then I wish you good luck.
Thank you.
In enrolling all these kids and the parents.
Thank you. Thank you very much.
And at this point of the pandemic, do you have at this point many kids hospitalized because of the COVID?
It goes up and down. So every time we sort of have a new peak, then we have new kids who are hospitalized with COVID. So there's always, it tracks with the infection rate. So, obviously last year at this time, when we had the big, Omicron, we had actually a number of kids who were hospitalized, and then it kind of goes down and goes up and goes down. So we definitely still continue to have children.
As the pandemic goes on, do you think that we're going to get to the point to be vaccinated every year, like the flu?
I think so. I mean, that's what the FDA was talking about yesterday. The VRBPAC, or their advisory committee, is thinking that we may potentially that there'll be, kind of every year looking, kind of maybe coming up with sort of what's the bivalent or trivalent, if they end up putting more kind of variants in there, and then getting vaccinated every fall, like the flu, until we can get a vaccine. So that the issue is that similar to flu, that the COVID obviously keeps mutating, right? And so there are always a few variants ahead. What's interesting is a couple studies just came out yesterday or the day before that did show actually that the bivalent booster from this fall did have better protection than the original monovalent vaccine against the newer strains of Omicron, including the one that's circulating right now. So it is definitely seems to be better. It seems to me to be better to to reformulate and to get that booster in the fall, even though we're kind of always chasing behind the variants. That even though that booster was made with the Omicron variants, that we knew about in the spring and summer, it is more protective than the original strain against the variants that are circulating right now.
Okay, thank you so much for your response.
Sure.
Dr. Mendez said just a great presentation and congratulations. And also Dr. Rodan, he has an intervention. Dr. Rodan.
Yes, great presentation. Thank you, Dr. Stockwell. The question that I have is, based on ethnicity, have you seen more incidents Hispanic, and what is the worst symptoms based on the ethnicity that you have seen on your research?
Mm-hmm. I think your first question was whether we're seeing worse cases in Latino families. I think what we do know is that there's definitely disparities in COVID cases, and so a concern for Latino families and actually African American families of potentially at the time have been higher risk of COVID, and so the concern would be, and what we'd want to understand as part of Recover is then what is the risk for long COVID? So are we seeing the same prevalence, in families? And I think for me, I think that all the symptoms are terrible. I think the worst symptoms I think that families talk about a lot are the brain fog, difficulty concentrating, and fatigue, because it's really hard for those kids to go to school because they're just exhausted and they can't concentrate. And really, one of the most important things that kids can do is to go to school and to learn. And so if they're missing out on some really a very, very important part of their life, and we're worried about that development piece. It's also a reason why we're doing a lot of the neurocognitive testing. We're starting at a very young age in Recover, because there's a lot of us who are concerned that, maybe that we want to make sure there's not going to be neurocognitive development problems in these young kids. So in, the 2, 3, 4, 5, 6, 7, year olds, where they're not, necessarily in school yet, and it's not coming, they're in school, but they're, not necessarily having the symptoms yet, to really understand those development parts. So that's the part that I'm most worried about, is actually is the cognitive development, and we're just going to have to see as part of Recover if we're seeing that or not.
And in my case, I would like to ask, I know we are almost ending the presentation, but Recover is still on the way, and I guess we need more time to keep watching the kids, and especially as you said, after you start with the whole population, the 20,000 nationally, you want to keep watching the long-term COVID symptoms kids until 1, 2, 3, 4 years more to watch them. However, I think COVID already has 2-3 years since it started in 2020, and I think you may have the enough observation in the children and adolescent population for those kids who they were known infected with COVID at any time during the pandemic, and they were totally asymptomatic, like no symptoms at all. Have you seen in your experience like a high frequency of long-term COVID symptoms or signs in those kids that were asymptomatic at that time they were infected?
Yeah, and that's actually one of the things that Recover is looking at, is making sure that we're also getting children who are asymptomatic so we can understand the prevalence or how many of those kids end up having long COVID. Certainly in the literature, there are children who are asymptomatic, or either asymptomatic or had very mild symptoms and end up with long COVID. So for sure, there's not a correlation between severity of symptoms with the infection and with long COVID. So we can't say, oh, the infection was mild, therefore they can't have long COVID. The infection was asymptomatic, so they can't have long COVID. That doesn't seem to be the case. And even for Miss C, there's a number of cases of kids who, again, had Miss C, had antibodies, never knew they were infected. And at the house, like they knew that someone in the house was infected, so they must have had COVID at that time and they were completely asymptomatic. So unfortunately, I wish we could say that we can predict, but we can't. And that's also one of the reasons for Recover too, is to really try to understand those risk factors. So, understand disease severity, understand kind of the social, biological, genetic, ultimately that could predict who might or may not get long COVID, but also the resiliency factors. Is there anything that we can do to kind of protect potentially in the future around the time that people have COVID to protect them from having long COVID? And then also obviously to ultimately want to get to a place where we can treat children and adults as well.
Yes, and that's very interesting regarding the vaccination options, because most of the parents, I think, if they have children with COVID and they were asymptomatic, then they will think that vaccination is not really needed because there is no risk. However, now with the information you're providing to us and to the community, we can realize that's not a fact. That's no it's not something that we have observed or confirmed, that we have to wait to see how it's going to happen with the study.
Yeah.
And Dr. Roa said that besides this is a great presentation, we hope you to come back at the end of the study to present the outcomes of the study.
Absolutely.
I agree, because I'm very interested, and I have kids, both have COVID in 2020, and they were totally asymptomatic. But now I will be aware about that this study Recover gonna tell us like a lot of information at the end of the study, and will have us to be more conscious about the risks that our kids could have after COVID infection.
So Marcia, I guess you're going to be one of the candidates for the study. You are
I know we can enroll you if you want to talk to Selma.
Yeah, you could be one of
I
the...
have 2 kids to volunteer. Yeah, so we invite to all the people who gonna see like Art Washington conference, and also will join us through our Facebook page later on, like for all those people that were not able to join us today, that go to the link I already posted in the comments of the conference, which is COVIDrecovered.org, right?
Well, so that's a national study. And if you want to reach us directly, maybe you can put our email, that Peds Recover email, because that will go to our team directly. So if you're interested in either enrolling yourself or wanting to have brochures and flyers to give out to your patients, if you email that peds_recover the email, I can flip, or do you have it? Maybe do you want to put it back? It's a peds_recover study.
Let me just post it right now.
Yeah, or I can put it in the chat also. Yeah.
Yeah,
let me put it in the chat, but it's peds_recover study at comc.columbia.edu. So I just put it into the chat as well.
Oh, PEDS. Okay.
Yeah, so that's how you'll get to our Columbia team. If you go to the main Recover, you can look for a study site, and then you can look for a study site near you. But if you want to our group at Columbia.
Columbia-edu.
.edu, yeah, CMC.
Okay.
At Columbia, yeah.
Perfect. Yeah. So for anyone, please join the study, and we want to thank you one more time for this topic that was very interesting, and you are welcome to come anytime with any other topic. We can also arrange a new conference about vaccination and to inform the population about COVID vaccine in kids 0 to 5, or also children and adolescents to up to 15, 17, 18 years old.
Absolutely. I would love to come back.
So thank you everyone for watching also and for joining us. Thank you for the people that was connected on Facebook Live, and to everyone who is joining us in the future. So there is all the info, and we are glad for this time.
Good night.
Hi everyone.
Good night. Thank you.
Good night.